All right. Well, thank you very much. And thank everybody for joining us today for our media briefing. We've been doing these on a pretty regular basis. Today's briefing the focus will be the role of nurses in the COVID-19 global pandemic and serving as frontline providers during the crisis. At the completion of our briefing, we'll post an unedited video of the questions and responses on our YouTube channel, and I'll send you that link afterwards for your use. And then we could also email you an MP3 audio file for folks that are interested in radio, or if people just use it for note-taking. A lot of folks do that as well. So now I'll turn it over to UNC Health's Alan Wolf to introduce today's speakers. Alan?
Thanks, Phil. Hey folks, May 6th today, and for the following week is National Nurses Week. We thought this was a great opportunity to highlight the fantastic work that nurses are doing across UNC Health, across the country, around the world. Joining us, we have senior nursing leaders from UNC Hospitals in Chapel Hill. Cathy Madigan is Chief Nursing Officer. Joel Ray is Chief Nursing Officer and Vice President of Patient Care Services at UNC Rex Healthcare in Raleigh. And Cecily Landis is a clinical nurse with the Medicine Intensive Care Unit, which has essentially been converted into a COVID ICU at UNC Medical Center in Chapel Hill. Cathy, would you like to kick us off with a few opening remarks?
Sure. Thank you, Alan. I appreciate the opportunity to be here. As you said, it's particularly meaningful that today starts National Nurses Week. I was reflecting yesterday, we were talking about the fact that the World Health Organization actually in January announced that 2020 is the year, International Year of the Nurse. And, you know, first of all, I think every year is the year of the nurse, but I also was thinking what a particularly appropriate year to be the year of the nurse, because I think while nurses work very collaboratively with our physicians and other leaders and other departments, nurses are really at the forefront of caring for these COVID patients. And so it really couldn't come at a better time to be the year of the nurse. And I'm glad that we have an opportunity to talk about that today and the important role that nurses play in all of this. So I appreciate being here.
Cathy Madigan.
Go ahead, Joel.
Well, thank you again for allowing us to be a part of this and for celebrating Nurses Week with us. I think we are here at Rex and nursing everywhere, really beginning to realize that we have a new steady state where we're going to be living in two worlds, taking care of patients who are going to be here with COVID for some time to come, as well as continuing to give the great care that we've always done. And so there's been a lot of focus in preparing to do that and to do that well. And I think that, as Cathy was saying, lining that up with all that's happening right now nationally in terms of this being the year of the nurse, I think nursing is just playing an incredibly important role in caring for these patients. And that's actually going to be for some time to come. I think we all thought it was going to be a sprint at first, but reality is that this is going to be a marathon, and I think our nurses are prepared to support our communities through this.
Cecily, would you like to say a few words?
Yeah, so like I said, I'm Cecily. I work in the medicine ICU. I'm a staff nurse, so I'm with a bunch of other nurses giving direct care. And we kind of always joked before that nursing was a team sport. You know, it's something that you always had to do together. You couldn't do it alone. And I think that shows even more now with how much things are constantly changing and the workflows and how we all have to really be there, sometimes 2, 3, 4 nurses to one patient to make sure we're giving the best care that we can for all the COVID patients right now that are in our ICU currently. So it's not really a joke anymore that nursing's a team sport. I think it's kind of showing at its finest that we all have to be there together to make this work.
Great. Now, so the idea here is that we'll take as many questions as we can get from the media, and it's a first come, first served. So anyone from the media, just step right up and ask your first question. And if you're having issues with being unmuted, please, you can let me know through the chat function as well.
Hi, this is Sarah Kruger with WRAL, and just wanted to ask any and all of you who are able to answer, you know, we know that there are going to be more COVID-19 patients, perhaps especially as the state begins to reopen. And I just wanted to check in with you all and see how you all are doing, how your teams are doing emotionally, knowing that this battle is not yet over.
Sarah, if it's okay, this is Cathy. I'll start with that, and I'd like Cecily to probably comment as well too. I think that what you just said is very true, and we're of course watching very closely as we start to lose some of the restrictions in the state. I think that we're very fortunate. We have some wonderful colleagues of ours who are keeping their finger on that pulse and working with all the nursing teams so that we know what to anticipate from predictions. But, you know, Joel said it really well. Early on, we thought we were really going to be in a very quick sprint. I think hospitals across the country have realized that that is not true, that we are indeed preparing and are prepared for having a lot of patients for a long time. Fortunately, we have flattened the curve in North Carolina a little bit, so it's not as much as we had predicted, but we're still going to be doing this for a while. And so now it's the dichotomy of how do we continue to take care of COVID patients as we also start to do surgeries and some other things that we've put off for a while. We really want to make sure we're taking care of the people of North Carolina for all of their needs. So, you know, I think Cecily can speak as far as how the staff feel, but I make rounds a lot, Joel makes rounds a lot, and I think our staff are doing a tremendous, I mean, an amazing job. Tremendous probably isn't even a good enough word. It's really quite remarkable how they've adapted to this, what they've put together, very creative things that they're doing to support each other. The hospitals are doing things to try and support them. So, you know, we are watching very cautiously as we move into the next phase of changing restrictions to see how that impacts the numbers of patients in our areas that are going to be COVID positive. Cecily, do you want to say something?
Yeah, I was going to say one thing Cathy mentioned that I think overall our staff, I think in general has kind of accepted, we call it our new norm now. Mm-hmm. We're all kind of at a level of acceptance that this is here. It's not going to go away tomorrow. We're kind of dealing with how we're moving forward. And Cathy kind of mentioned like the hospital being prepared. And I know one thing that's been really great on our unit is our management has been wonderful at kind of seeing what the next step is going to be, and instead of waiting until that next step comes to start implementing some of the steps or new interventions we're doing, they'll start like a few days ahead of time or even a week ahead of time. So when we hit that next point, we're already in that flow, we're already in that motion, it already seems normal. And I think that's one thing that's really helpful in us coping as we are constantly transitioning as this evolves, as we understand this is a new thing. And another thing that's been really helpful is even before COVID came, UNC had this great initiative for resiliency across our units. So even before COVID started happening, there were a lot of really great coping and gratitude initiatives put across our unit. So already having some of that strong positivity across the units, I think, gave us a good starting point as things slowly kind of to evolve and change throughout the hospital. We have boards in our room that help us put positive comments about our shifts, and those are always great to reflect upon. We're grateful we have PPE. We try to really focus on the positives of what we have versus how things are constantly changing and how we have to adapt. And we're pretty accepting of our new norm, I think it's safe to say.
And Joel?
Thank you, Cathy. I would say that one of the things that we've had within our nursing culture across the UNC healthcare system for some time is identifying 3 good things as part of our regular meeting forums as we gather and huddle. And that's just become part of our culture. And so I think that has really helped our teams to focus on the things that are positive and really generating that excitement when we have a patient who is COVID and being discharged. And then I would also want to say that I think our nurses feel the tremendous partnership from our citizens and community as people have followed the guidance around social distancing and the tremendous difference that that has made in terms of the volumes that we see. And I think there's been such an outpour of gratitude and appreciation from the community, people giving everything from food to PPE and other things to express their appreciation for healthcare workers and specifically for nurses. And that has brought a lot of encouragement to our team, and we're very grateful for that too.
Great point.
Hi, may I jump in with a question for Ms. Landis? This is Lynn Bonner from the News and Observer. I'm wondering how you handle the emotional part of the job when it comes to patients who are coming in with a dreaded disease and are separated from their families, don't know when they'll see them again. I'm sure that must be sort of some extra trauma on their part that you kind of have to take on. How do you handle that?
So I think that definitely is a new thing for us. I think being in an ICU, we're kind of used to seeing some very dramatic, traumatic things, diseases, comorbidities that kind of come in together that make it hard to challenge to care for a patient. But we're used to having families there to support our patients. We're used to having families there to kind of guide us and letting us to know our patients a little bit better, things specific to them. And with our families not being there, I think that is the most challenging part for us as ICU nurses, or as people are transitioning into different type of care modes. Having that iPad there for people to kind of spend their last moments has been really hard on us as nurses, because we know that's really important to closure for families. But I think that's one thing that kind of motivates us to want to take that extra step, to want to make sure we have iPads available, to make sure that we make time to where we can stay in the room as long as the families want to. It kind of almost, as much as it can be hard for us, it almost gives us a little extra motivation to take that extra step to make sure our families and the patients get what they need emotionally too. And if we can get that met for them, that changes a lot for us. So I think it just kind of adds more motivation to give that good care for our patients.
And Ms. Bonner, if I might just add too, one of the things that Rex and the medical center has put in place is the way in which we give care to our families. We've actually called Carolina Care. And so we both have Carolina Care Liaisons, and those are folks who work within the hospital who right now may not be as busy as they would be, because we were trying to prepare for opening up our units for COVID patients. So all of those folks have been deployed as liaisons, and they go in and spend time with the families. They help those who don't know how to FaceTime with their families. Our chaplains are doing a super job of connecting with families and spending a long time with them as well on FaceTime. And neither of us have stopped allowing visitors at end-of-life situations too. Both Rex and the medical center have allowed that all along. So we think that, of course, is a different stage than if you've just been in for surgery for 2 or 3 days. We are asking folks to still stay away until we get to a different place with that. But I am actually really proud of the work that people have been doing to make sure that we are connecting families with their loved ones, because it's hard for the nursing staff, but it's hard for the families, of course, as well too. It's not the way that we usually practice. We really embrace families. So I think that we're trying to do the very best to make sure that that connection still stays in place.
Well said.
Great. Additional questions from the media, please just jump right in.
This is Rose Hoban from North Carolina Health News.
Hey, Rose.
So, one of the issues has been, we've heard a lot of talk about people practicing at the top of their license. What have been some of the changes you've seen in your practice as you kind of expand it to meet the needs?
I would say that at this point, I really haven't seen very dramatic changes in that yet, particularly in the ICU, and Cecily can comment on that. Actually, really, I think throughout most of our units, both at Rex and the medical center, we all along have felt like people need to practice at the top of their license. I think that, it depends. I look at New York and some of my colleagues up there, that certainly changed for them as they had to take care of large numbers of patients, and each nurse had to take very large patient load, and that is not where we are. So I feel like people are empowered to make independent decisions. We work extremely collaboratively with the physician teams and others as well too. So I've not seen a big change in that. Joel, you might want to comment. I don't know if that's true for you or not too.
I agree. It really hasn't been required of us yet beyond the typical practicing at the top of the license that we try to do with all of our clinicians. I think maybe what you're hearing and referencing is really moving to disaster plans to help us manage perhaps 200 ICU patients, 800 to 1,000 acute care patients in a in a 439 licensed bed hospital typically. That does require a lot of different organization in terms of how we would deliver healthcare. And so we have designed and have plans ready to integrate in a very specific way our intensivists and hospitalists and nurses and CRNAs and advanced practice providers to work more closely together to care for that broader population, to really the purpose of that being to extend our critical care capability across a much wider population of patients than what we typically care for. And that is a very different practice. It's what we've been training for, but to this point, we've not had to implement that. And we're all grateful for that, but we're ready.
But I'm sure that some nurses have had to learn some new skills and some new skill groups. Cecily, what have those been, and how's that been? Like, it's got to be a really steep learning curve.
So actually for the ICU, a lot of these things that are coming out about COVID, like proning patients and putting them on their stomachs, those things are actually not new to UNC. Those are things ICU nurses at UNC have been doing, at least in our ICU. So we've felt very comfortable. One thing though is that we have needed a little bit more extra nurses in our unit in order to make sure we can do those types of things. And UNC has been wonderful about getting other nurses from other care areas, having them come over to the ICU and having the ICU nurses kind of train them up on our different therapies, our different drips that we tend to run, kind of the workflow of our ICU. So if we get to a point to where they need to be pulled to come help us out in the future, they're already ready, they're prepared, they're comfortable, they know the environment. So I think that's kind of one thing that's changed a little bit, is just pulling different nurses from different care areas to get them kind of ICU ready in case they have to be there. But as far as actual practices or things that we're actually doing with our patients, not too much has changed from that, because our ICU, it's called a medicine ICU, but it's primarily a respiratory focused ICU. So thankfully, a lot of these things that are being expected to be done with COVID are things that we've already been following for similar respiratory viruses that we typically care for. So that's been kind of helpful for us, that we're doing things that we are already familiar with.
And I'm sorry if I missed a little bit of your question as well too. Cecily said it really nicely. I think that the ICU nurses, it hasn't been as much, but what we have done both here at the medical center and at Rex to prepare for what we initially thought was very large numbers, we have had to train the step-down nurses to work in the intensive care unit arena. And then the floor nurses as well have been trained to move to the step-down areas. And so we've done a lot of online training, but we've also done a lot of, as Cecily referenced, we've done a lot of in-person mentoring and training as well too, so that if folks have to work outside of their normal areas, they will have some comfort level in doing that.
The only other thing I would add is more broadly, we are incorporating telehealth into our practices at a faster rate than what we had anticipated prior to COVID. You know, with limited numbers of providers, you're always wanting to make sure that we're only placing in that patient's room those who absolutely need to be there. And so we've had a lot of integration of telehealth in terms of physicians doing consults virtually, as well as some rounding virtually, and nursing is a partner in that. And that's really been new for us. It was already being introduced, but the pace has certainly increased over the last few weeks.
And
Hi.
Yeah, go ahead.
I'd like to ask the managers how many nurses you've had out sick or in quarantine, and how that's affected your staffing.
Sure, I'll start with that. I'm looking for any fake wood I have in my office to knock on. We have not had a large number of nursing staff that have been quarantined. The majority of those were those who were either exposed outside of the hospital, actually, or who had a relative who came down with COVID positive. So, and we have staffing models that we have gone through every iteration of that. What if we have 10% of our staff out? What if we have 20% of our staff out? What if we have 30% of our staff out? So we have models for all of that. It's really, we're doing a lot of team nursing, which is not what we do as much anymore, but we really looked at how would we handle it if a large number of our staff were exposed or were out or were sick. and had to really come up with some different plans for what we would normally do. But that's really based on a model that came out a while ago that we've all looked at and said, okay, how would we team up and take care of a large number of patients if we have less nursing staff? Joel, I think that's what you all have been doing as well too.
Very similarly, I think
Yeah.
we have had only a total of like 8 or 9 coworkers who have come up positive, and most of those were very early on in the observation of COVID cases in the state, and were community transmission. I think so we've not really experienced a significant staffing impact at all. We did have a few more people quarantined, especially on the front end when we weren't able to test. That drove a little bit more, but we also haven't had high patient volumes. So it hasn't been challenging for us in a really significant way at all, and we're grateful for that, and we hope that continues.
Media questions, please just step right up. If not, we can ask questions. We've got some as well.
Can I ask another one?
Sure, Elaine, go ahead, please.
Great. For Ms. Landis or anyone, what we've seen sort of globally is what's coming out of New York and the hospitals, you know, really some traumatic scenes. And I'm wondering how that compares to what's happening at Rex and UNC. Is there sort of like a frenzy, and I mean, what's happening here in comparison to what we've seen happening there?
Sure, I'll jump in if that's okay too. You know, I'd say first of all, 3 of us would say that we're extremely grateful that we are not New York, because that does look, you know, for anybody pretty disconcerting when you see all of that as well too. I do think, I mean, our epidemiology team tells us that, you know, because North Carolina jumped on social distancing so quickly, that it really has helped us to not see that same kind of, you know, very large response to COVID that they have had to deal with. That's not to say, though, that those units who are taking care of the COVID patients, like Cecily's unit is doing, are really, you know, very stressful, very busy. Everyone's in their garb with their, you know, their shields on, their face shields on. And Cecily could talk about how they're managing that, how they're switching back and forth with that. So it's almost 2 worlds. I mean, the worlds inside those units are really very busy, very high stress, very acute. And then, you know, the rest of the hospital is still busy, not as busy as we normally are because we did clear out. But I would just say, I think we're extremely grateful that our numbers are not coming true. But it's not to say that we don't have some really sick patients in here right now who are COVID positive. We are grateful, as Joel mentioned, that we have some that leave, and that's a celebration. But not everyone does, and it can be a very hard time, I think, for, you know, all the staff involved in caring for those patients. So, Cecily, do you want to comment on that?
Yeah, I was going to say it's definitely stressful. Like we talked about, how we're nursing is different. We have team nursing models now. We're staying in our PPE for up to 2 hours at a time. We have some nurses wearing N95 masks for 2 hours, and they're getting their little bruises on their nose. I mean, some of these things are happening in our ICU. And even though these things are stressful and kind of unfortunate, we always say that we are thankful that we're not New York. We are thankful that we're not Washington. We're thankful that North Carolina kind of saw some of the writing on the wall, and people did social distance. People are washing their hands. People are staying at home, because this potentially could be so much more worse. And how stressful it already is, and the idea of what it could potentially be, is a little scary. But at the same time, we're thankful that it's not there. We're not New York, and that people are taking this seriously and taking their measures to try to reduce the spread of COVID right now. So it is more stressful than normal, but we're still not New York, which is nice.
The only thing I would add is I think there are some visible differences, especially as you enter our buildings, where we have stations where we're checking all of our visitors and patients as they enter. We're screening to make sure that they have not been symptomatic, that we're giving them a mask. Everyone walking around the building, patients, the limited visitors that we do have, our staff, everyone's wearing masks. It's a changed environment that is very, very visible to us, throughout our day. And there's no doubt it feels different. It raises the level of awareness that our world has changed. But I do think that our staff are doing very well, and we're learning to adjust and live in this new world and environment.
And if nothing else, we're all a lot better with Zoom meetings and WebEx meetings than we ever have been before.
And we're good at learning to read each other's eyes, because that's about what we see most of the time.
As well, too.
That's true. I never realized how much I relied on lip reading until the mask came into play. I'm like, can you say that again?
Cecily, could you share maybe, being on the front line, how have things changed maybe just on a day-to-day basis, things you have to do differently that you did not have to do previously?
Yeah, so they have changed a lot. Typically, you would kind of come in, we'd get our big shift report on all the patients, get our assignment, you go find the off-going nurse, you get report on your 2 patients, and then it's you and your 2 patients, and you get your meds, and you kind of are responsible for those 2 patients, and you get to make a lot of the clinical decisions, help facilitate the care. You're kind of at the center of that 1 to 2 with those patients, and it's all on you. However, now we're doing team nursing. So the way it works is you and 1 other nurse are assigned together, and 1 person goes ahead and puts on either their capper or their N95 and their face shield and their gown and their gloves, and they go into what we call the high-risk zone, which is essentially an area marked off where all the COVID patients are. And that nurse will be in directly taking care of the patients, those 2 patients, for 2 hours straight. All she's doing is direct nursing care. And then if I was her counterpart in the low-risk zone, which is where we aren't keeping patients, it's where we're keeping medications, supplies, workstations, things like that, I essentially get her medications, get her supplies, get anything from what we're calling the clean area, low risk, and then dropping them onto a cart on the other side of her high risk area for her to collect. And those are our 2 independent jobs for 2 hours. And then after 2 hours, she's going to go to a special station. They're going to tell her specifically how to take everything off. And then after she takes everything off, I go to my station. They tell me specifically how to put everything on. And then I'm going in for 2 hours straight in the same PPE, the same capper, the same gown, the same everything, going from my 2 patients, just doing direct patient care. And while she's collecting my supplies, she's charting, she's grabbing meds. And that's just what we do every 2 hours until the shift is over. So it's very different to give constant direct patient care in the same gear for 2 hours, and you're sharing responsibility with another nurse for 2 patients. And it's really different compared to just being you and your 2 patients and kind of running the show on your own a little bit. But it's been working well. Everybody has kind of appreciated it. We've had enough help to do this, because it does take an extra certain amount of nurses to do this. And I will say a lot of us feel like our area or our unit staying more clean. There's not as much spread because we're not going between the med cart, our med cart to the rooms, to supply rooms. It's kind of easier to really separate out our high risk area from our low risk area. I think that's kind of been our biggest change right now, and having somebody watch you take your PPE on and put your PPE on, we're not really used to that. We're kind of used to just doing it ourselves, but it's definitely a helpful precaution to make sure that we are safe, our patients are safe, and we're keeping our work areas safe.
Was it 2 nurses assigned to 2 patients or 2 nurses assigned to 1 patient?
2 nurses are typically assigned to 2 patients, unless there is a patient that's so critical that they're requiring extra care. Then it might be a 2-to-1 situation, but typically it's 2 nurses to 2 patients.
Thank you.
We are almost out of time. Are there any final questions from the media? We have time for probably one more.
Yes.
Question. Go ahead. I've asked one already.
Okay, I have 2, but maybe mine will be quick. I just wanted to see, as you all are thinking about the possibility of more patients as things reopen, if you could kind of just give some insight into what any preparations look like on a nurse level for those patients.
Sure. We certainly, one of the things that we did to prepare for COVID patients was to clear out some of our units. So we certainly have nursing staff because we haven't seen as many COVID patients as we thought that we were going to. We have nursing staff that are available and ready to start taking those patients as we ease up our restrictions and start with some of our, more necessary surgeries. We will have completely different units for those patients. Our COVID unit patients are very separate, as is Rex as well too. So we have staff, we have supplies. I think the thing that we're really looking at is how are we going to test those patients? How far ahead should you test those patients? And there's a whole team looking at the processes for making sure that when patients come in, they're safe, and again, our staff are safe as well too. So I think that's the bigger part of it. We certainly have the resources to be doing this at both places, but I think we just are being very cautious in terms of making sure that we're doing the proper testing on the patients when they come in as well too.
Great. Well, thank you. We're out of time. Thank you all for joining us today. We really appreciate you taking the time out, and we hope this was helpful for you. Again, we will post a video of the entire briefing on our website, not on our website, sorry, on YouTube, and then we'll send you the link for that, and you can also get the audio file if you would prefer to have that. So thank you so much. We're moving to, right now, we're probably going to go into a once a week instead of twice a week format here, but we'll have another one planning for that next Wednesday. So thank you very much. And that concludes our briefing for today.
Thank you.